So, what is the learning objectives? Describe the importance and scope of sexual health issues with a spinal cord lesion. Describe how the basic neuroanatomy of the spinal cord lesion can impact basic sexual function for women and men. And describe the basic treatments for female and male sexual dysfunction following spinal cord lesion, and describe the basic problems for male fertility and pregnancy for females, and describe the basic treatment for fertility for men with spinal cord lesions. And a little bit of a repetition, what you already had. Spinal cord lesion changes sexual function in almost every individual with a spinal cord lesion. And all people with a spinal cord lesion maintain the capacity for sexual thoughts, desire, and sexual acts, as said before. People with disabilities often express their sexual concerns to the people they feel comfortable most with. And that's why it's so important that all of us working in the spinal units are aware of these things and can talk with the individual. And as JJ said before, actually at night time, in particular the nurses, often have the challenges. So it's important that they also know the basic thing. Also, as JJ said, that sex can mean different things to different people with spinal cord lesion, including but not limited to sexual identity, having sex, sexual pleasure, intimacy, fertility, maintaining relationships, and finding new relationships. So there's a difference between sexuality and sexual function. And here, primarily sexual function after the lesion is brought in. But it's much broader, of course, when we talk about sexuality, which includes, as you already heard, emotions and everything related with the situation before, during, and after sexual activity. And you already have this definition, human sexuality, because that's from the WHO, is how people experience the erotic and express themselves as sexual beings, the awareness of themselves as males and females, the capacity they have for erotic experiences and responses. Sexual preferences or orientation describes the sexual attraction to another person of the opposite sex, of the same sex, of both sexes, or attracted to no sexes in a sexual way. Okay, there are several factors which we have to be aware of when we talk about what can affect the sexuality. So, you have the pre-existing sexual status, you have specific physical effects of it, you have the relationship factors, of course the psychological factors, and what we do, the iatrogenic factors. So be aware, wean down, if at all possible, antidepressants, antispasmodics, and narcotics. So also as mentioned, the sexual function includes the desire, the sexual interest, the way the genital organs respond to sexual arousal, genital arousal, and orgasm and ejaculation for men. A lot of the issues are the same for men and women. Impaired motor function, hand function, sexual position options, altered sensibility, areas of numbness or hypersensitivity, and the risk of pressure ulcers, incontinence, urinary bowel, spasticity, and pain. Of course, you have to be aware of these issues, and of course also think about how to treat it so you do not impair the sexual function further. The orgasmic sensations are usually altered. Orgasm is an individual feeling, and this involves many external and internal influences, as we talked about, as psychological as well as physical nature. The physical orgasm as such is due to muscle contraction in the sexual organs and the pelvic floor. If we look on the female responses, vaginal lubrication and perineal engorgement occur through psychogenic or reflex pathways. The psychogenic lubrication is more likely with more sensation between the umbilicus and what we call the pocket area, T11L2. And there you can go to what we call the A step, I will come back to that, to see more. Intact bulbocavernosus or anal wing reflexes generally indicates the possibility for reflex lubrication. You can go to the American Spinal Injury Association website, go to Learning, and here you have the A step. That's a e-learning program on autonomic anatomy and function. And the goal of training of the autonomic standards is to learn more about the normal autonomic functions, understand the changes in autonomic function following SEI, and use the autonomic assessment to document and classify remaining autonomic neurological function. I know you will have that later on in a lecture today. So overall, what's the treatment? Shortly, wean from medications if you can, because, as we said before, it decreases libido, arousal, and orgasm. If the vagina is dry, use water-based lubricant to avoid vaginal friction or tearing during sexual intercourse. Women should be counseled that orgasm takes longer to occur, and use of a vibrator or clitoral vacuum suction device may improve orgasmic ability. And again, spasticity, especially in femoral adductors, may interfere with intercourse. Regarding fertility, after a trauma, many times there will be amenorrhea for a period of a few months, and the fertility then will be intact in most women. So there's a need for contraception before resuming sexual activity. Regarding the contraception, we advise low-dose estrogenic contraceptive pills. Of course, you have to be aware deep vein thrombosis, smoking, obesity, inactivity, etc. For intrauterine devices may be used, but it is potentially hazardous due to the lack of sensation, particularly in tetraplegia, where a lack of hand function will prevent them to actually check the device. So barrier methods such as diaphragm can be used. May need assistance to insert and check. Men should use condoms at all times for safe sex, and particularly for contraception. But of course, each woman should discuss it with a physician to find for her the best method of contraception, considering frequency of sexual intercourse, level of injury, degree of function, and various risk factors. Pregnancy. While a woman with spinal cord lesion remains fertile, pregnancy can result in high incidence of bladder infections and skin issues. And seeding and transfer will require adjustment. We usually take them in 2 weeks before term in our unit, because also if they have complete lesions, they may not be aware when the labor starts. Delivery. The women may not be able to push and may therefore need assistance during delivery of the baby, including forceps. There may be greater risk of perineal tears because they don't have the pelvic floor muscles. there's a risk of unattended delivery, and of course, risk of autonomic dysreflexia in women with high lesions. And that's, as also already stressed, a very important issue. If we take an overview of the male sexual response, generally the majority of men with spinal cord lesions can attain an erection after injury, either through psychogenic or reflexogenic pathways. But of course it depends on how complete the lesions are. Again, you can go to the A step to see more about this here. However, these erections are often unreliable or inadequate to valid sexual intercourse, duration or rigidity. The male sexual response. It is important to know about the reflex erection can occur by direct stimulation, like doing catheters or working in physiotherapy, and can be embarrassing. And of course, the first time the man he experienced that, he will not know what it is about. And therefore it's important in such situations that the individual know that erections can occur after spinal cord injury without any sexual stimulation. And it's just due to reflexes. So that's important for us to explain that. Dependent upon level and completeness of spinal cord lesion, you will see impaired erection for sexual intercourse we talked about, impaired fertility, and actually both due to the ejaculatory dysfunction in 85% of the individuals and abnormality of sperm already in 95%. And you'll see that starting from 3 weeks after the spinal cord lesion. So what can we do? Again, consider if they need all the medications you give them, which may contribute both to erectile dysfunction and whether they can be changed. You may use physical methods, you may use pharmacology, and there are many more, as you can see in the module for doctors, and which also will come up in lectures later today. So, if there's a reflexogenic, you can either stimulate by manipulation or vibratory stimulation. Then you may use the venous constriction ring if there's sufficient rigid erection, but it does not last. Then that's the easy way to do it, or you can use also vacuum erection devices. The important thing about using the constriction ring is that it should only be there for 30 minutes due to the risk of pressure and ischemic complications to the penis. And the same is actually for the vacuum device. We did not have very good experience with the vacuum device in our unit. So we, in particular, after we got the pharmacological possibilities, we don't use it at all. Because after we got the PD5I, then it is really a game changer. It helped actually 80% of our individuals with spinal cord lesions. Adverse events are usually mild, headache, flushing, dyspepsia. The important thing is that nitrates synergistically intensify vasodilatation with severe drop in blood pressure, and which is potentially lethal. So you should not co-administrate within 24 hours these two drugs. And as you may know, Viagra actually was firstly developed to pulmonary hypertension. And probably some of the patients there, they found out there was adverse events they liked very much. For these drugs, the effects are within different time windows, and the duration have different lengths, of course, to be aware of that. We usually start with Viagra and use a lot more Cialis today than we did in the beginning. If you cannot get it in the way with the tablets, the injection is very good. Today we only use the prostaglandin because it has less side effects, and the success rate is 95%, and the erection is very fast. There may be pain, and priapism is much less with PDE1. We actually did a study where we asked those who had this opportunity and asked them how much they used it. And actually very few used it, but they said to know we can use it if our partner like it, but usually we found out other methods to be together with. And that's an important message also to us. But of course, if they like to have it, then it is good that we can provide it. So what is the strategy here? If you can use venous constriction band, do it. Maybe vacuum device, otherwise Viagra and these drugs. Second choice will be the intracavernous injections, and of course other methods will come on later today. The ejaculation dysfunction, only 15% of men with spinal cord lesions will be able to obtain antegrade ejaculation by masturbation or sexual intercourse. So what came up now, actually the penile vibratory stimulation, has now been on the market for a long period, and electrical stimulation will come also on later today. But actually, I'm honored to say that it was one of my PhD students who actually developed this, Jens Sørensen, who is now professor in urology at the University of Copenhagen. And what we found out in his PhD study is that when you use a vibrator, the crucial thing is the amplitude of the vibrator. So it must be an amplitude of 2.5 millimeter, otherwise it will not function. Again, possibility of autonomic dysreflexia is important. Just to say, this is what we actually send home with the patients many times, so they can use it at home. This is more what we may use in the clinic when we make the ejaculation for fertility purposes. Because actually, some of our patients today, they're not going to have fertility all the time, but they may use it to decrease their spasm, and they may use it to increase their bladder capacity, which we have proven in other studies you can do with penile vibratory stimulation. So you may use it in the morning when they do the toilet anyhow. And what we found out is that 25 to 65% pregnancy rate with vaginal insemination and penile vibratory stimulation at home in selected couples. And we can have 50% pregnancy rate after PVS and other techniques in combination with intrauterine insemination and various in vitro fertilization methods. So also as Shenshak Windale, he said before, carefully communicate to the individual with spinal cord lesion. They should feel comfortable. Important to feel one way, explore one's own possibilities, and exploring new, intact, sensitive body areas in order to get more pleasure. The therapy should be tailored for the preference and goals of the particular person or couple. And as also mentioned already, don't forget the partner. Use educational lectures, use written material, internet, use individual counseling, use counseling by other individuals with spinal cord lesions. That's maybe the most important at all, the peer counseling. Remember, a spinal cord lesion will not protect from contracting a sexually transmitted disease. Use protection. So, the take-home messages. People with spinal cord lesions maintain the capacity for sexual thoughts, desire, and sexual acts. Wean from medications that cause decreased libido, arousal, and orgasm. Women with spinal cord lesion may have decreased vaginal lubrication, but are normal fertile. There's a risk of unattended delivery, and during delivery the woman may not be able to push. Men with spinal cord lesions have usually impaired erection and limited fertility. Erection can be improved utilizing venous constriction band, vacuum device, and PDE5 inhibitors, but be careful with nitrate drugs. We use nifedipine instead of. Intercavernous PDE1 is the second choice. Male fertility potential can be improved by penile vibratory stimulation. So these are the messages. Thank you very much. Hope you